Hi, everybody. Thank you so much for coming. Hopefully we'll have a few more trickle in, but we really appreciate you coming, and I think we'll have this, with a small group, can really have a really nice discussion around some of these topics. I'm Tracy Madsen. I'm from Brown University in emergency medicine, and we're going to be talking today about clearing up the confusion, emergency department management of GCS-15 brain bleeds. And this didactic was sponsored or has been sponsored by the Neurologic Emergencies Interest Group. So if any of you are not part of that group and want to be part of their group, we do a lot of cool sessions, collaborations, and it's really a great group of people. I'm going to start with introducing the scope of the problem, and then I'll be introducing our esteemed panelists here. So in terms of epidemiology, if we think about all traumatic brain injuries, this accounts for about 2.5 million ED visits per year. And we know that the vast majority of these are mild TBI. In terms of getting into the epidemiology of mild TBI and then subsets of mild TBI, it gets a little bit more difficult to measure. But the thing that we're going to be focusing on today is adults with traumatic ICH, so a bleed on their scan with intact GCS. Here are our session objectives. First, we're going to define and describe the epidemiology of traumatic ICH with GCS-15. We're going to describe the evidence behind our current management strategies. We're going to describe sources of practice variability using a survey that one of our panelists created and performed, which we'll show you in just a minute, and talking about a little bit about future directions for research in this area. We have 5 topics that we're going to be going through today, and each of these topics is going to be discussion-based with our panelists. The first topic is going to be reversal practices, so reversal of anticoagulants in the emergency department. The second topic is transferring patients for neurosurgical consultation and or trauma admission, and this is more applicable to community hospitals or smaller hospitals without neurosurgical capabilities. The third topic is repeating the head CT for stability. The fourth topic is the role of observing patients with traumatic ICH and intact GCS, observing them in the emergency department and or discharging from the ED rather than admitting them. And then finally, predictors of high-risk cases or poor outcomes. And for each of these topics, as I have sort of mentioned already, we're going to be talking about what's the evidence, are there current guidelines to guide what we're doing in terms of management, and then what does the practice variability across sites look like. I would like each speaker to introduce themselves. We have a great group of speakers here, and I think will be wonderful discussions.
Thank you very much, Tracy. I'm Maya Babu from Boston, a neurosurgeon on the panel, so I have to thank Pierre and Tracy for kindly allowing me to join you.
I'm Debbie Madhok. I am from the University of California, San Francisco. I practice at Zuckerberg San Francisco General Hospital. I'm in emergency medicine and neurology, and I'm an emergency medicine physician and neurointensivist.
My name is Pierre Borczuk. I'm at Mass General. I work with Maya. I'm in the emergency department, and that's it.
My name is Kiersten Gurley. I'm at Beth Israel in Boston, as well as at Mount Auburn in Cambridge at a community hospital.
My name is Peter Pruitt. I work at Northwestern in Chicago.
Great, thank you. Let's start with some cases to illustrate some of the points that we're going to be discussing in just a little bit. So our first case is a 56-year-old male, history of Ehlers-Danlos syndrome, atrial fibrillation, mitral valve replacement with a mechanical valve on Coumadin, and multiple prior strokes. This patient had had multiple falls, with the last fall being 3 weeks prior to the visit, and apparently was seen in an outside hospital where the CT scan was negative for any acute bleed. However, the patient has had persistent symptoms. Over the last 3 weeks, he's had difficulty focusing, a dull-sided left headache, and endorses a mild left frontal headache as well. Denies visual changes, focal neurologic symptoms, including weakness, sensory changes, bowel or bladder function, and that's the story. And here's his non-contrast head CT. Can someone point out the abnormality? The answer is on the slide. And we're going to brave soul, I'm going to point out any abnormalities they see. Anyone on our panel? It's a little hard to see from their angle, but so
I'm going to guess the subdural.
yeah. So we see a left-sided subdural. If you look on the left side of the CT here, we have left-sided subdural, which is likely from this previous fall that we've discussed. The maximal thickness was about 1 centimeter. So in terms of management, this patient was reversed with vitamin K and PCC, was admitted to the neurosurgical floor for observation, had serial CAT scans, and had his warfarin restarted on hospital day 3. So this is an example of traumatic ICH with intact GCS that we're going to talk about some of the controversies about management strategies. And our second case is a 90-year-old female. She has a history of hypertension, hyperlipidemia, glaucoma, diabetic. She was on aspirin, 81 milligrams, and her chief complaint was a fall backwards down 3 stairs with an occipital head strike and no loss of consciousness. Again, this patient is alert and oriented ×3, non-focal neurologic exam. This slide doesn't have the answer, so if any of you want to venture a guess as to what the abnormality is. Does anyone see any abnormalities? Say that a little louder. Perfect. So right here, if you look, there's a traumatic subarach. In terms of management for this patient, her aspirin was held. She had a period of observation in the emergency department, which is an issue we'll be talking about in a couple of minutes, and was eventually discharged from the emergency department after about 8.5 hours. Was also discharged on seizure prophylaxis. Okay. I'm going to turn it over to Pierre to talk about his survey.
So we did a Redcap survey to kind of figure out what the practice variability is and ask some questions as to, do you transfer patients with these minor head bleeds? Do you consult neurosurgeons? Do you reverse them? The Redcap survey was initially sent to the Facebook EM Docs group, and then was sent to ACEP engaged forums and as well to members of CORD. It was very much a convenience sample. It's probably skewed by people who were touched by my begging and pleading for them to fill out the forms. So we're going to be discussing some of the results of the survey. So the respondents, one question was, are you at a level 1, 2, 3, 4, 5 or non-trauma center? And I think this is kind of an expected distribution. There were a fair number of respondents who were not at a trauma center. And on the next slide kind of gives you respondents by region. It seems like people in the West are less sensitive to my pleading and begging for filling out the survey. But other than that, the distribution seems to be fairly reasonable.
Okay. So we're going to start with Debbie Madhok talking about reversal practices. There's a pointer on here, too.
All right, good morning, everybody. So I'm going to talk a little bit about anticoagulant reversal. This topic is really, this one is very straightforward. Patients who are anticoagulated do much worse than patients who are not anticoagulated. And these bleeds blossom. They blossom fast, and they affect outcomes. So the GCS-15 patient easily becomes a patient who's no longer GCS-15. So this person needs to be reversed. We have lots of options for reversal. If you're talking about a patient who has a finding on CT, has a head bleed on CT, and they're on warfarin, most sites typically break them down by what your INR is. It doesn't necessarily have to be 1.9 because different sites use different INR cutoffs. And obviously, if your INR cutoff in this example, which I pulled off from another institution's guidelines, if the INR is less than 1.9, just vitamin K is given, and if it's greater than 4-factor PCC will be given with vitamin K. The hot topic right now is when you have something on your CT and you're on a factor 10A inhibitor. I won't go into too much detail, but for right now, as the guidelines stand right now, it's 4-factor PCC, okay? Your institution may be changing practice, but right now it's 4-factor PCC for evidence-based guidelines. And then if you have a head bleed on CT and you're on dabigatran, then you will be giving idarosizumab, okay, Praxbind, and this is all evidence based. Antiplatelet reversal is a little bit murkier, okay, but I'll say that it's hard to know even when a person's on antiplatelets whether they actually have a platelet dysfunction, but studies have shown that patients who get any sort of transfusion do worse, okay, including platelet transfusions. And if you were to take literature from the non-traumatic ICH, so something from the patch trial, and you apply this to TBI, and I know these are two different entities, then you know that these patients have worse outcomes when it comes to morbidity and mortality after a platelet transfusion. I will say, though, that in my practice, this is not evidence-based, but in my practice, if, a neurosurgeon, I sometimes, defer to the neurosurgeon. If they're in a case and they open up the skull and the patient's on an antiplatelet, they're on Plavix or on dual antiplatelet therapy, and it bleeds like stink, it's going to be up to them in the OR because they're the ones who are like seeing it right in front of them. But the evidence-based guideline is that you don't give antiplatelets, you don't give platelet transfusions for patients who are on antiplatelets. And that's it for me.
Have you used the new factor 10A reversal agent yet?
So that's a very, very controversial topic, okay? I don't know, I'm not sure if you guys, for show of hands, do you know about the new factor 10A reversal agent? Okay, so most of you guys seem to know about it. It's very, very pricey. And I work at a public hospital, okay, an urban safety net public hospital. So that comes with a real cost. I will say that the evidence for PCC as a reversal agent for 10A inhibitors is really good. And our own internal data shows that the patients are not blossoming with the use of 4-factor PCC. I think that the reason why it's so controversial is because PCC is a pretty good agent for factor 10A inhibitors, okay? But there is an agent that's very, very pricey that is likely also a good agent. And I think it's going to come down to hospital administration whether it's it's worth it to pay for that medication.
I was talking to our pharmacist, and that drug Indexanet has now risen to the 11. Has in their budget of the most of all the meds is now number 11 because it's like $50,000 a dose, and you need. Yes, and but they're very reluctant to give it to us, and we really have to speak to you guys about that, right?
Yeah.
Because there's a timing issue.
Right.
When do you?
It has to be given early on, very early on.
Well, it wears off, right?
Yeah. So Maya, I don't know what your feelings are. Since we've opened up this controversial topic, I guess we'll continue on it. Yeah. but if Maya, if you want to talk a little bit about your practice using it, every hospital also is like having since it's a $50,000 medication, and it likely at this point right now, I know that at our hospital we have patients are heavily covered by Medicaid, and it's still unclear whether it's going to be covered by Medicaid. So you have to. There are a lot of restrictions. I think every single hospital across the nation that has ordered it. It hasn't even been received. I think by most hospitals has very severe restrictions on which specific patients to give this to. So I'm interested to hear, Maya, which patients you're using it for.
Yeah, no, absolutely. I do just wanted to mention, I think what you said was exactly right in terms of kind of the more traditional agents being highly effective. And absolutely, we also get a lot of pushback from pharmacy if we try to order it for a patient. I think it's kind of a combination of factors that we look at. One is severity of the bleed, assuming we're taking the patient emergently to surgery. Two is the INR, or if we don't have an INR proxy, when the last dose was, or how thoroughly we think the patient's anticoagulated, whatever parameters we have to assess that. If we see any evidence of active bleed on a scan, that type of thing, it increases our desire to use the agent. But it's certainly, we do get a lot of pushback, and I would say the timing and the logistics are often a barrier. Even if we get approved for a dose, actually getting it to the OR, because we don't want to hold things up, so we just keep going. So I would say it would be interesting to actually look at how often, we have it in the patient's system before we make incision even, because it can, it's not something we necessarily wait in those truly emergent situations. I think it's a good agent to have. It would be nice if it was more available so that we could actually get a better sense of how it guides our clinical practice.
Don't be surprised, that it's not part of any guidelines right now, so it's not, there wouldn't be an evidence basis to give this medication. But don't be surprised, because when, you're talking about people who are coming, from Mass General Hospital, don't be surprised when, there's going to be creep and a domino effect when the hospitals in your city start to get it. Don't be surprised if it's not even evidence-based if everyone starts using it, because everyone's going to want to use what the hospitals around them are using.
I think the other issue is having a protocol, and I don't know what you guys do, but it's still going through our P&T committee at our hospital, and we're struggling with what would the protocol even be, how would we select patients, and maybe it's based on some of the factors that you were describing, but we're not quite there yet.
Yeah, and in terms of the platelets, it seemed like we were giving platelet transfusions to everybody, even on a baby aspirin.
Yes.
What is going on with that
Yes.
now?
No, thank you. So I actually trained outside of Mass General, and Pierre can say I arrived in September, so fairly recently, and I just actually found out from Josh that this was a practice of giving platelets, and I guess my residents have been doing that without my knowledge or awareness. But absolutely, I think it makes no sense to me. Platelets for baby aspirin, 325, et cetera. And so I've been trying to instill in them. We look at the platelet count before we, actually administer platelets, but otherwise we use these, factors in terms of reversal agents. So thanks for mentioning it. I wanted to point that out as well.
Thank you. So Kiersten Gurley is going to be talking about transferring for neurosurgical consultation.
Oh, thank you. Hi, so I'm Kiersten Gurley from BI, and I work both at an academic level 1 trauma center, but also at a community site. And about 2 weeks ago, I was on shift at the community ED and had a patient that came in, 90 years old. She was not in anticoagulation. She fell, hit the back of her head, was neurologically intact, no other injuries, and was found to have a small traumatic subarachnoid in the right frontal region, which hopefully you can appreciate on CT. That's her CT. And, I knew she was okay. She was somewhat frail, and I thought she would benefit from physical therapy, increased services at home, and so wanted to get her at least dialed in and not discharge her right away. The family and the patient felt very strongly that they wanted to stay at the community site. They did not want to get transferred to the level 1 trauma center. So I was able to, we don't have neurosurgery in-house, I was able to call them. And the attending neurosurgeon could hear about the case and actually see the images that I could upload. And they basically said, you do not need to transfer this patient. There's nothing more that needs to be done, no Keppra, no need for repeat head CT, no need for a neurosurgeon to see the patient. And so the combination of those two, the recommendations and the family's wishes, I was able to admit this patient to the hospitalist service overnight without much issue. The next day, there was a slew of emails, and the daytime hospitalists felt somewhat different about their ability to care for this patient should they worsen in any way, or they felt uncomfortable with no repeat head CT. And so there were, lots of emails, and it really brought up the question. I think there's a hesitance to care for these patients locally, at least on the medicine service, and I think any of us that work in the community may have experienced this. And there's a real perceived medical legal risk. In Boston, were this patient to have done poorly, the neurosurgeon was 10 minutes away, but I know that's not always the case, depending on where you are in the country. And there's a financial burden, so both for the patient to be transferred, for the medical system as a whole, and it's a real inconvenience. So I know also someone who works at a level 1 trauma center, I often get these transfers, and they are promptly seen by the neurosurgical NP and discharged within 12 hours after, never leaving the emergency department. And I don't know if any of you have experienced that as well. So do we have guidelines to address this and the disposition of these patients? And the short answer is not really. So we don't have clear guidelines to tell us what to do with the mild traumatic intracranial hemorrhage patients. I think oftentimes these patients are transferred. And really, what we do know is the type of the intracranial hemorrhage is related to the risk of decompensation. So if it's a subdural more than a centimeter, if they're on anticoagulation, they're at much higher risk for decompensation. And I think, transferring those patients is quite reasonable. Dr. Borczuk was involved in a study here that showed age, sex, GCS, deficit, aspirin use, Plavix, subdural, less than a centimeter, subarachnoid, and IPH were not independent significant predictive factors in a study of about 200 patients. There's some research in the 2010s that showed that often patients will show neurologic physical examination signs prior to decompensation requiring a neurosurgical intervention. And then the big protocol looked at about 3,000 to 4,000 patients and was validated, but that was really in the setting of acute care surgeons caring for these patients, and that's not necessarily what we have if we're trying to admit this patient to the hospitalist. So it doesn't fully pertain. So to have some insight from Maya would be nice on this as well.
Thank you. Yes. Yeah, so absolutely. I think I think the case you outlined is kind of the classic case in terms of something that's not going to require intervention. And I think, too, in terms of laying the groundwork, had spoken to the family, the patient. There was a desire to stay at the local hospital, so it wasn't even a push to try to transfer or escalate care to a level 1 trauma center. I think, we certainly hear this as well if we try to admit patients to a medicine service. I think a couple things. I think, certainly our hope is to have a more robust, we're trying to actually develop right now more of a telehealth service, and we're kind of going through the medical legal issues related to that, akin to a stroke telehealth service, but I think it would be incredibly helpful just to maybe allay some of those concerns from outlying hospitals. And so what that would entail is documentation. So, someone would get paged and say, can you review this image, speak to emergency physician in that hospital, hear about the patient, and then document in the chart, have spoken, we do not believe that this patient is, requiring a higher level of care or requires a transfer at this time. And I don't know from my colleagues here if that may help with some of the medical legal questions, but I think certainly from our standpoint, we would love to keep those patients in the community and spare them an unnecessary transfer.
I think that's a challenge in our system of hospitals, that it's not really in terms of our culture. It's not totally accepted to just talk to a neurosurgeon on the phone without having them evaluate the patient, examine the patient. But I think that's a great idea to have some sort of set protocol with telemedicine, and so then I think I would feel more comfortable and more covered. Because I think that's a big thing, is a medical legal issue. And then the other issue is, will your hospitals admit these? So I think it would definitely have to be part of the protocol, and I think that would be a great direction to move in. I work at a community site as well, and we often have to transfer elderly patients 10 minutes away to go there and have a neurosurgeon say, you're fine, you can go home. So it does seem like a lot of excess resources and unnecessary transfers.
And I forgot to mention, too, certainly the advanced age of this patient in particular, a lot of times the family, not to say that this particular scenario is at a risk of expansion or blossoming or requiring surgical intervention or even, an external ventricular drain or anything like that. Apart from that, patients' advanced age, comorbidities often have very strongly held goals of care beliefs. And so we will see patients who are transferred to our facility and, well, I wouldn't want surgery or intervention anyway. So I think having some of those discussions up front is very helpful. But in my mind, this is a classic patient. I would expect delirium, more of the sort of general hospitalization medical issues instead of anything from the head bleed.
Do you want to talk about your survey?
So we had this question that we put out. What percentage of patients will get a neurosurgery consult? And by no surprise, there is variability. I think the Western state, I got a feeling the Western states are a little bit more adapting of the big protocol. Big the people who created the BIG protocol are geniuses, because BIG stands for Brain Injury Guidelines, so it's big, you know. So that came out of Tucson in Arizona. So I think they have a protocol that omits neurosurgical consults and repeat CTs in one category of their patients, but it's still, you know, common practice. And I think on the next slide we have do you place patients with mild traumatic intracranial hemorrhage? You know, do you think they can stay at a community hospital? And there seems to be kind of universal agreement that, you know, maybe yes, but we don't do it.
Right. I think the medical legal issues are the biggest, probably. Any other comments from others in the group? Practices? You transfer them from your community sites?
I mean, we usually, so this was the only case, and it just happened a few weeks ago, where I was able to admit to the hospitalist. I don't have the ability to admit to either acute care surgery there or neurology. So I thought it was successful. There was some backlash on the other end. I do think it was what was right for the patient. She ended up doing very well. The repeat head CT didn't show any increase in bleed. I wish there was a way of doing that more routinely. I think that my ability to speak to the neurosurgeon on the phone and know that they reviewed the images and I could, you know, document their name, I felt fine from a medical legal standpoint in admitting that patient. And so I think getting the whole hospital on board and the hospital service on board is going to be maybe slow to come, but hopefully that can happen as well.
I just have a quick comment, because there seems to be a difference in the practice from the second case and this case, because they both were traumatic subarachnoid hemorrhages with an intact GCS. The first case was prophylaxed with levetiracetam for seizure prophylaxis, and this case wasn't. In the first case, it wasn't actually indicated, so there is no indication for seizure prophylaxis in these cases. Intact GCS with its sole traumatic subarachnoid hemorrhage.
That's good to hear.
Oh, and if I could just make a comment, you know, because obviously Keppra is sedating, and so we are, at least from a practice standpoint, a little bit more reticent in the elderly population to prescribe it unless we see a clear indication or concern for cortical irritation. So there are situations where we either do 250 BID instead of our standard 500, or even document. We don't think the risk-benefit ratio actually outweighs, and would recommend against it. But if there's any concern, patient may need it in a delayed fashion.
And if you're interested in kind of future study ideas, probably looking at seizure prophylaxis in these patients in a trial setting, there's really been nothing since kind of the Temkin 1990 study that looked at kind of very, very brain-injured patients and the results of seizure prophylaxis. We really haven't done anything in that area since that time in terms of an actual trial. So I think that that's a very interesting area for us to consider expanding, because I think if you look at, there have been a few things published on like health-related quality of life in patients with intracerebral hemorrhage, or, you know, and things like that, and there's not been a lot of signal that there is benefit to seizure medications in these populations.
That's a great question. And then we have another survey question. I think all patients with mild traumatic ICH need a neurosurgical consult.
Again, it's like little surprise that the folks at level 1 trauma centers may not think that's important. But clearly, as availability of neurosurgical consult is not there, the feeling is that they probably want a neurosurgical consult.
Great. All right, let's move on to repeat CT for stability.
So one of the initial studies looking at the utility of repeat head CTs was in 2006. It was a study that was in the Journal of Trauma, and it looked at, you know, are repeat head CTs in patients with these mild injuries really helpful? And, you know, we love to be comforted. It's comforting to get that repeat CT. Stability feels good. We swaddle ourselves between the CT number 1 and CT number 2. That's 6 or 12 hours apart. But the real answer from this study, which was kind of a smallish group of patients, was that in patients who, you order a routine repeat head CT, the patients who you're going to intervene are the patients who tend to have some type of neurologic event before they even get that routine CT, and then you get a CT, and they have a, either progression of their lesion, maybe require a procedure, and that was the outcome of this study. So there were 37 patients who got repeat head, 179 who got repeat head CTs. 37, the CTs were actually worse, but the ones that actually were intervened were the ones that had neurologic complaints, new neurologic events, even before that repeat CT was ordered. So get a repeat CT based on symptoms, but not necessarily routinely get CTs on everybody at 6 or 12 hours. The average time between CTs here was 13. Even though I say that, we love repeat CTs. And they're so easy to get, too. There were some risk factors in a regression analysis of this study, and I think the important part in those 4 variables to predict who's going to have a worse CT at least is they had cases where they did a CT too early, and in certain conditions where you're anticoagulated and you're not totally reversed, you can potentially get progression of CT in patients who get CT'd pretty early. So that's one take home from this study. We did kind of a similar study. We had a data set, and we had a data set that had up to 975 patients. And you fall in love with a Venn diagram in 4th grade or something, and then you get to rekindle that affection anytime you can. So this is what this Venn diagram is. Oops. See if I can get the pointer. So there's 73 patients who had a worsening CT. There are 54 patients who had worsening neurologic whatever, and that was defined really broadly. It means like if you're going to get called to see the patient if they have worsening headache, they have nausea, vomiting, they're lethargic, they're agitated, they have a post-traumatic seizure. Those were kind of broadly coded as a neuro event. And then you have patients, there were 58 who had neurosurgical intervention. The real joy of the Venn diagram, the thing that's most meaningful, is there were 3 patients who had a worsening CT, neurologic deterioration, who had an operation. That's great. That makes sense. That makes perfect sense. The truly scary part of this chart is one of these numbers, and I think the scary one is that one. So these are patients who had a worsening CT without any neurologic new complaint, who, based on the CT results, got a neurosurgery evaluation that says this patient needs to go to the OR. Those 3 patients had subdurals of greater than 1 centimeter that got larger. They were either on aspirin or warfarin. So those patients exist if you have a large enough data set. Another number, kind of always like to think of is number needed to treat. And we figured out that you would have to do 300 CT scans, routine repeat head CT, to get that one that the neurosurgeons think they need a neurosurgical procedure in the absence of any new focal complaints. The other side of this is I have no idea what makes the neurosurgeons operate on a subdural patient a couple days from now, 6 weeks from now. I really don't have a feeling. Is there a rule? Is there? No.
A lot of variability.
Yeah, okay. So sometimes I see patients get taken to the OR a couple days later. Sometimes they get follow-up in clinic, and I guess if their subdural is still there,
Yeah.
you drain them, or?
Yeah, or if the patient, headaches.
Yeah.
So sometimes we'll have conversations, oh, I want to watch it. Okay, then a couple days later, the headaches aren't getting better. Okay, I'm ready to consider surgery.
So that's the story on repeat head CTs ancestrally. I would probably always do them in patients who you're in the process of reversing some type of coagulopathy, and then you want to, your coagulopathy is reversed, you check for stability, and then it gives you that warm feeling when it's stable. But the data is telling us routine repeat head CT in patients without any new symptoms is just a waste of time. I think I'm doing topic number 4 also, and that's the role of the ED observation units. Do you guys have observation units in your place? So we put a survey. This was the medical legal question, and it was, do you feel as if even with discussing with a neurosurgeon, would you discharge a patient with, one of these mild traumatic intracranial hemorrhages home after 6 hours? And it seems like, the answers are, again, all over the place. I suspect that, there's practice variability, and we're afraid of something, afraid of being sued. If we create a protocol and a standard of care, the lawyers are only interested in standard of care. So if we all have a standard of care to evaluate these patients, observe them, discharge them, or whatever it is, we're not going to get sued. There's also tremendous variability that we found in the survey as where do you admit these patients? Do you send them home? Do you admit them to an observation unit? Are you admitting these tiny bleeds to an intensive care unit? And we still found that tons of patients are still being admitted to an ICU. And I'm not sure these patients need an ICU level of care. But that was a result from the survey. Going back to the observation unit, our observation unit started off as, the standard chest pain observation unit. You throw in a couple of asthma patients, a little cellulitis. But over time, there was acuity and diagnosis creep, and patients started getting sent up for TIA evaluations. People got sent up with minor head bleeds. So we wanted to get a feeling of what the minor head bleeds patients were like. So we looked at a 4-year data period, and there were 371 patients who were observed. And when I say observed, about 2/3 went to our observation unit, and the remaining third, since there were no beds in the observation unit, that just hung out in the ED during the observation period and then went home if they did okay. And the traumatic subarachnoid hemorrhages, those patients uniformly did really well. And there were about 120 of them. And it makes sense. Those lesions are not expansile. The patients do well. There were some subdural patients. The neurosurgeons decided to operate on some of them. Again, I don't know why, but there must have been a reason. And then the cerebral contusions, there were some that got worse. Out of this group, 12 patients got admitted. 8 of those 12, they got admitted for other medical reasons that probably led to their fall and trauma that were more pressing than their intracranial hemorrhage. We did a little bit of follow-up. The fault of the follow-up is the patients who didn't follow up were the ones we sent home and died. But at least the ones that followed up, there were 2 patients who had delayed drainage of their subdural hematoma. So then there was a couple of years of putting patients up in the observation unit, and there started to be significant acuity creep. We had patients in our obs unit with GCSs of 11 and 12, and we decided to create a more detailed protocol based on data that we had established, mostly having to do with subdural hematomas. And the protocol was, and you have to understand that because we're at a level 1 trauma center with neurosurgeons available, we can afford maybe to place patients with larger subdurals there. So our criteria for our obs unit was subdural hematomas of less than 1 centimeter, traumatic subarachnoid hemorrhages, small contusions / intraparenchymal hemorrhages, There were patients who went to our OBS unit despite our protocol who were on anticoagulation. That was the most common violation of this protocol. And so we were able to decrease admissions from the observation unit that were due to acuity creep. We're continuing this protocol and monitoring that. So if you're interested in creating a protocol to put patients in an observation unit, I would start off by the low-hanging fruit, which is the traumatic subarachnoid hemorrhage patients, because those patients universally do well, and then maybe creep into the subdurals, maybe 5 or 6 centimeters or less are probably the safest. Yeah, millimeters, yeah. Right, exactly. I think I'm going to have Peter come up.
We have maybe a minute or two for discussion.
Okay,
if there are
yeah,
any
great,
issues
great.
within either the repeat CT for
Great.
stability or discharge from the ED. What are your thoughts about repeat CT? In our institution, it's protocol per our neurosurgeons that all of these patients get 6 hours.
Yeah.
And so it's a constant, kind of push and pull.
So
Do they have to stay in the ED for 6 hours? Is it really necessary? And so I'm hoping we're moving towards fewer of those.
Yeah, so despite studies that we've done in our own department, our repeat CT rate probably went from 86 to 90%. I think now it's in the 60% range. So there's real improvement, and I think you guys are helping us out with that.
Yeah. We certainly, we're trying, we're trying to be, more thoughtful about repeat CTs. What I've observed periodically is sometimes, trauma surgery, or other groups will kind of weigh in and say, maybe this patient would benefit. I don't know if you're seeing that as well, but at least from our standpoint, we're trying to be a little bit more consistent, but it's a work in progress.
I had the feeling that the trauma group who was involved in the no need for repeat
Yes.
CT, the Dr. Velmaho's group,
Yes.
says, we don't need to do a repeat CT on those. But
Yeah.
I think there's still variability within our
Exactly.
department. Yeah.
And I was going to ask, actually, I would love to hear your thoughts. So would part of the concern with patients who are observed and then dismissed be allayed in any way if we were to have a follow-up appointment set up? Because we have a head injury clinic, and we usually, those patients are, folks that we have to monitor because of the size, what have you. But I'm kind of curious if expanding the parameters of that would actually be beneficial, if that would help maybe with some of the concern.
Well, it would really help at a community setting.
Okay.
Like the question I get asked is, you're at a community setting and you want to discharge a patient with traumatic whatever, who did they follow up with?
Yeah.
We don't have maybe a neurosurgeon who can follow up easily on those patients, and maybe, creating some type of enterprise-wide follow-up system may be useful.
I definitely think that the follow-up would be great. And at a community site, either the ability to follow up with a neurosurgeon, also the ability, if we could have a way for the hospitalist to be able to call the neurosurgeon if they had a question, if the patient was to worsen, and have that teleservice in place. I think those two things would really help keeping the patients in the community.
I will say, I actually just conducted a large survey of trauma centers, and actually asked about referral to TBI clinic. I don't want to give away too much because it hasn't been published yet. But I will say, though, that the overwhelming response was that TBI clinics or concussion clinics are a very limited resource. And even at sites that do have one, it is very hard to get into them. So I'd say that in the ideal setting, yeah, of course, if we can get a referral, if we can get a patient to clinic in the next couple of days, that would be awesome. But I think that the resource is very limited, and there's so many barriers to actually getting those appointments from the ED.
Great. I think we'll move on to our last topic, predictors of high-risk cases and outcomes from Peter Pruitt.
All right, so I'm actually going to flip the topic on its head just a touch and ask, how do we define low-risk hematomas? Because you've heard a lot of different people, and some of this is actually going to be kind of spaced repetition in a very short space of what we've talked about before. We've heard a lot of people talking about kind of these different criteria. But you'll notice that, and you'll notice as I kind of go through the next set of criteria, that everyone has a slightly different definition of low risk. So are they stable to be managed in the community? Is it just they don't need neurosurgery? Is it they don't need immediate neurosurgery? They may be stable to get a burr hole drain 4 days from now, but that's a different form of stability. Is it stable neurologic status? That may have to do with kind of their underlying delirium dementia picture in addition to their kind of TBI picture. Is it a stable CT scan? Do we care about, their radiographic status in addition to their clinical status? Or is it no need for critical care intervention? Is it people who don't need to be tubed? Is that kind of our definition for stability? Or is it some combination of the above? And so I just want to be thinking about that as we go through each of these criteria. So Dan Nishijima in 2014 published a rule about patients with traumatic intracranial, or a tool for patients with traumatic intracranial hemorrhage, asking whether they needed to be admitted to an ICU. And the rule that he created said yes if they had GCS of less than 15, non-isolated head injury, age greater than 65, or evidence of swelling or shift on the CT scan. He defined low risk by did they get any of these critical care interventions listed up here. This was a tool that was prospective but never validated, and it was not particularly specific, as you can probably tell, especially in kind of the subdural population where the median age is typically about 70. So you're losing a lot of your subdural patients by this rule. The brain injury guidelines, as Pierre already talked about, were retrospective analysis kind of that their methods are really interesting. They kind of did a very large retrospective analysis and then did kind of a consensus. And what they found was that they created relatively complex criteria with lesion-specific components, and with the overall goal of determining which patients could be managed without neurosurgeons in that kind of big one group over there. So small subdurals, small intraparenchymal hemorrhages, or subarachnoid hemorrhages that are traced were able to be managed without hospitalization and sometimes without neurosurgery consultation. Even the big two guidelines, they argued, could be managed with hospitalization but without neurosurgery consultation. But again, that was in the care of acute care surgeons who kind of see this on a much more regular basis. So those are the two kind of generalized criteria we have. We then have kind of lesion-specific questions. Subarachnoid hemorrhage, it's really hard to find kind of criteria that make subarachnoid hemorrhages high risk because they're very low risk. There was a meta-analysis of patients with traumatic subarachnoid hemorrhage, which showed they have a 0.0017% pooled risk of neurosurgery. They have about a 5.7% pooled incidence of radiographic progression, and about 0.75% of them will have neurologic deterioration. So these are very, very stable patients. I think there are a lot of kind of equipoise questions to be answered about kind of even anticoagulation reversal in these patients. If only 0.0017% of them are proceeding to surgery, you may not need to spend the $50,000 to reverse them.
And I don't think the risk is the subarachnoid hemorrhage, but it's the risk that the second lesion makes itself aware and they get a subdural afterwards.
Cerebral contusion, no one has published like a thing on traumatic kind of intraparenchymal hemorrhage, so we really don't know much about that. Subdural hematoma. There are two kind of tools for subdural hematoma. The most recent, this was actually just published in Journal of Neurosurgery this month. But Orlando was a person, not a place in this circumstance, but created a decision tool to predict the need for neurosurgical intervention. He identified hematoma thickness and acute on chronic hematoma as the two major predictors of this rule. We actually had an abstract earlier this week doing this validation on the kind of some MGH patients. But what we found was that there was an area under the curve of 0.94 for this two predictor model. So it predicts very, very closely neurosurgical intervention. They had a maximum sensitivity cohort, which identified patients with less than about 2.35% risk of neurosurgery. What they showed is that if you have an acute on chronic hematoma and it's thinner than 2.25 millimeters, or a non-acute on chronic hematoma, so an acute subdural or a chronic subdural that is less than 6.25 millimeters, you're very unlikely to need neurosurgery. And so those patients, if neurosurgery is your real benchmark, then those patients are stable. And that model had a sensitivity of about 100% at that cutoff and a specificity of about 53%. And then Pierre and I actually created another rule to evaluate for kind of a composite outcome of death, neurologic deterioration, and need for neurosurgery. We had 6 criteria up there, which were use of warfarin or clopidogrel, greater than 1 discrete hematoma, hematoma thickness greater than 5 millimeters, any midline shift, and GCS of less than 14. This rule was sensitive, but a little bit less specific, especially than the Orlando rule. It's also a little more complicated than the Orlando rule, but to defend my own rule a little bit, it also it looks at a much broader series of outcomes, and those outcomes may be important to people who are managing these patients in the community. And that's kind of the state of the evidence and in terms of defining low and high-risk hematomas.
Thank you.
Thank you.
So I think we can open up to questions from the audience and or further discussion from the group. Do we have any questions?
Hey there, Mark Courtney from Northwestern. Thanks a lot. This is really fascinating, and it's also great to have a multidisciplinary kind of panel and some people from outside of emergency medicine, so thanks. And you may be able to address this as well. Peter and I have talked about this a bit, but I would just see if the panel could comment a little bit on the inter-observer agreement of some of the measurement of some of these things, right? I mean, it is puzzling to me sometimes to what degree radiologist X is going to read a CT as positive versus radiologist Y. And especially when we're talking about measurement and numbers of things, that there can be a fair amount of uncertainty as to whether this is, 2 millimeters, 3 millimeters, and maybe where the field is headed or could head or should head for that.
I could, I've read so many radiology reports, and there's definitely the question of the vanishing bleed on the repeat head CT. And I guess these traumatic subarachnoid hemorrhages, they redistribute, or, right? So you may not be able to see them as they dilute themselves in CSF. So that may be a vanishing bleed. And in terms of measuring, I mean, do we really care if the subdural is 1 millimeter, 2 millimeters, 3 millimeters, or 4 millimeters? I assume the radiologist can distinguish between, an 8 millimeter versus a 2 millimeter subdural.
Yeah, I mean, I guess that if some of these rules are using a cutoff of a certain number, then the reliability of how to read that number becomes kind of important.
Yes.
I think that's probably, there are already volumetric analyses that are starting to pop up for subdural hematoma, and kind of looking at this idea of, can we use 3D volume to evaluate these? Can we use things like that? And can computers give us a real idea of, like, the same way we do with kind of intracerebral hemorrhages and things like that? Can we say, this is like a 30 cc
What the
hematoma.
volume is instead.
Yeah.
Yeah, and I think that when you look at it, if you look at, I look at CTs obviously all the time, and if you look at the subdural, they can sometimes be different thicknesses depending upon where you're looking at it. And I think that Peter brings up a good point, is that the future is going to be machine learning, right? These are going to be read by a machine.
Yeah, and we're actually exactly looking at more AI type of framework to try to get standardized measurements, but it is a challenge. Angles change, et cetera, so absolutely.
I think the next group's already coming in, so.
All right. I think we'll wrap up there. Thank you very much.